Oh, hello.
Okay. Hello.
Not yet.
Hello. Can you see us and can you hear us?
Yes, we can see and hear you.
Good. First of all, I wanted to thank SJ again to have me here for the live case. Second, that for the first time, I think I have the privilege to be in his room actually. In the new hybrid room here. It's wonderful. It has very spacey, excellent equipment. And the team, I actually feel very much at home. Everybody knows me and I know everybody here, so it's very good to be home again. I hope that will be reflected in our final result, that we feel very comfortable working here. Having said that, I also know that SJ has a good challenge for me, and I was hoping that Jean-Claude had to do this case, but he successfully avoided that. So here we are working on a very interesting case, and Dr. Kim and Dr. Lee to my side here, very, very good friends for a long time. Dr. Kim has done the successful deployment with Jean-Claude, so I hope he's not going to sabotaging me. And he will be able to present the case maybe?
Yes. We just prepared the second COBAL case. It's very challenging. So this may be 74 years relatively older patient and 160 centimeter of the height. The past medical history, less than MI. So Euroscore is just around the 20. Baseline we just preparation of the T. However, I just briefly some number of the summarizing the aortic valve area 0.5 is very tight stenosis, mean pressure going to 81. Annulus diameter annual T is 24 millimeter. Ejection pressure normal. So as I already mentioned about that, some CT in so right side at 23.9 and left side at 25 millimeter. The perimeter is 86 millimeter. Next one. Yes, just look at it. The looping picture exactly similar to the some root angiography. Right side. Next one. A truly tricuspid valve. However, in a right side left coronary cusp in a small fusion, and very heavily calcified in locating in the non-coronary cusp. Next one. Coronary height to left main to the annulus in a 20, and very anomalous RCA origin, and the longest one is 40 millimeter, just ascending aorta. Next one. Iliofemoral artery is beautiful imaging. So.
Yeah. So well, thank you very much. Can we just go back to the CT? So we would like to. Yeah, that's a good picture here. This is actually a very nice picture, and.
Moving.
I don't know whether you agree, but it was initially thought this is a bicuspid valve, but looking at it a little bit more carefully, it's tricuspid, and this type of calcification is actually something that I don't like, and this is what we talked about this morning. It's not so much about the total calcium content or the Agatston score or whatever score you take. It's the distribution, and what you see here is these big chunks of calcium which you will not be able to eliminate by pre-dilatation or no pre-dilatation. But I have to say, thinking initially that was bicuspid, and as I said this morning, I always or usually pre-dilate the bicuspids. We were discussing this here from the size and from the procedure, and maybe while the valve is being loaded, we can show the angiogram. I don't think they have seen the angiogram yet. Mm-hmm. And maybe you can discuss with us what your suggestion would be. Obviously, we have made up our mind here, but we would like to discuss this with you because this is quite a challenging case. And talking about this morning's case, and prediction of PVL and things like that, I think it would be interesting. Can you see the angiogram?
Yes. Oh yes, we see very nicely, and we agree with your last comment. It's not a simple case for sure. Now, having said that, I will be very pleased to see, after the crossing of the valve, where will be located your wire, because all the question between bicuspid or tricuspid here is to see if between the non-coronary and the right coronary sinuses there is a commissure or not. Is it a raphe or is it a commissure? If it's a commissure, then your wire will go there, and it looks like your wire is going there. Of course, it's coming back, but I'm sure you modify that. It looks like you are inside a commissure here. So this is more or less validating your point of view of a tricuspid and not a bicuspid. So far, of course, this is where I like to use, the balloon when I'm not sure between bicuspid or tricuspid. Despite here, I'm going for tricuspid, but maybe I'm still wrong, so we never know. So using a balloon will also tell you, if you do an angio, if you are, with the bicuspid or tricuspid, it could help to assess that. Yes, Eberhard?
Yeah, I think this is a very fair comment, Jean-Claude, and I'm really very happy that that you're there, because obviously, is this the echo?
Yeah, that is echo.
So
real time? Yeah.
So there's a huge, I don't know whether you can see the echo, but there's huge septal hypertrophy, which makes it also a little bit, see that?
Can you see the echo?
Echo.
Yes.
Okay, there.
Yes, we can see.
Yeah, so this is going to be big, and I think the comments are very well taken, Jean-Claude. In this case, as I said before, I'm not pushing the non-pre-dilatation issue unreasonably, and here I would actually feel more comfortable to do that for the reasons that you mentioned, and also to make sure, to see how the calcium is moving, deciding bicuspid, tricuspid. Bottom line is, looking at this, I think we should agree that the pre-dilatation here makes a lot of sense. We have prepared a 23, but looking at the anatomy, I think you would agree this is a big anatomy, or a large anatomy, how you call it. And we were discussing the 31 or the 29. We did an angiogram with a graded pigtail, and I initially thought it was a 31, which, looking at this, would not be my favorite valve. Bottom line is, with the a perimeter of 86, it fits both the 29 and the 31, and we decided discussing this to use the 29 valve instead of the 31. I don't know, can you comment on that, Jean-Claude?
Oh, I loved your choice, and I think you explained very nicely finally, because irrespective of the measurement, we all know, that 31 is not a very simple valve to implant. And where you are in borderline, you have to really discuss it 2 times before choosing it. Because here you have an annulus that fits finally at 29, at the upper limit, but is 29. So it will be very interesting to see if you have a major leak when you do a balloon valvuloplasty, because if you have a very minimum leak or no leak, then be very comfortable to use a 29.
Did you see that, Jean-Claude?
I think that you are struggling to advance this damn balloon.
Yes, you're right. So forget about the pigtail here for the time being, but I think we're okay now. But it tells you that we probably are in the commissures between the calcium. So I think it's good that we did this pre-dilatation thing. Shall we do this now?
Yes. Eberhard, you have the TE with you, so normally the echography should be able to tell you that. This is one of the advantages of using general anesthesia and TE. Because if you see the wire of the balloon at the commissure, then case closed. It's not a bicuspid for sure.
How much?
180. Let's do the pacing.
180.
180.
됐어요?
예, 됐습니다.
맞았다.
No,
Pacer off.
you have to do it again.
Yeah. But you can see. Okay, so we put it a little bit deeper. The pigtail is crawling up there. Pacer on.
Pacer on.
No.
pacing's problem.
Okay.
Okay. No. pacing's problems.
한 2, 3비트 걸리고 있어요.
잡았어. 위치 바꿔야겠어. 페이싱 위치.
So the pacemaker is not
Eberhard.
captured.
Yes. Change the some pacing.
Okay. So
Yeah.
Eberhard,
Yes.
this is Yang-Ko from Severance Hospital.
Hello.
I have a more basic question. Yeah, do you hear me?
Yes, I can hear you well.
Do you hear me? Yes, this is Yang-Ko from Severance Hospital. I have
Yes.
more basic question. This is a relatively young patient in 70s,
그러니까 이게
and
그냥 들어가죠.
the patient's presenting slide showed relatively few comorbidities. So what makes the high Euro score in these patients? So is this a good candidate for TAVI procedure at all?
Okay. Dr. Kim, I have
Yes.
to defer that question
Yes.
to you.
Yeah,
Very reasonable, yes.
예. 잠깐만 여기. 이거
Can we
좀
just,
we just talk that later.
yeah, we talk, can we answer that question a little bit? Let's see that we get this thing done here.
어때요? 페이싱 테스트?
페이싱?
테스트? 오케이 됐어. 잠깐만요.
오케이.
We just testing.
Okay.
I just preparing.
Pacer off. We come back to that question, okay?
Yes.
I just want to make sure that
Okay.
we are.
Yes.
Pacer on.
페이싱 on.
테스트.
테스트.
So nice and Joe, eh?
Okay,
So that's
pacer off.
very
Pacer off.
good.
Off.
Very instructive.
이렇게 참.
Okay. So that was a 23
보여주세요.
millimeter balloon.
보여주세요.
So what's the rationale of your selection of 23 millimeter balloon for pre-deal? And do you have any change of your mind to choose a bigger valve from 29 to 31?
No. I actually can you I keep,
Yes,
wait,
yes.
keep the- I actually think this is much in favor of the 29. We've discussed this many times. I'm not against the 31, but if I don't have to to use it, then I don't. And I much rather use the 29. And in this case, if the 23 millimeter balloon seals, then I'm comfortable with the 29 millimeter valve. If this would be a big leak, then I would probably be in doubt, and we could rediscuss. We have to put the pigtail back. Yes. The pigtail, the graded pigtail, is not the best one to do that. As you know, we have
Why
to
is
probably or exchange.
와요.
But my preference for the balloon sizing is exactly that. That we don't take the 25. I take the 23. We're still conservative, because in case we have aortic insufficiency and all of this, I'd be conservative with the. This is good. With the balloon, I'm sure we have to reposition the. I don't like the position of the wire, so we have to do all this again.
Wire. What about the wire? Wire position.
좀 쏘세요.
Yeah. So let's. We're still in LAO here, and I would like to actually reposition the wire. The wire is not the one that I like, I have to say.
피그테일이요?
Can we try to
피그테일 좀.
피그테일.
the pigtail?
Pigtail.
I like the 1 centimeter tip. This is the 6 centimeter tip. Because we don't need the soft part in the ventricle. We need the stiff part, and you have a lot of 6 centimeter soft floating around, which you don't need. And it's barely. And I would think if we had problems with the wire, with the balloon already, we would actually be encountering a little bit more problems with the. Can we go to RAO?
Yes.
Feel free to make comments anytime you want.
Subtract.
So this might.
So far we are following you struggling with this ventricle, which is hypertrophic, and
Yeah.
unfortunately for you, you face a quite different complex situation together with hypertrophic, bicuspid, extremely calcified valve. And,
Yeah.
And
So we'll
why
see.
is not optimal? It's
No.
fine. I think it's fine. If you go back to the other projection to have a look,
Yeah.
for us to when you align the frame, you know the valve.
Are you
I
ready?
think it's way better now.
다시 한번 인젝션. 한번 더.
Okay. We do an injection.
인젝션 한번 더 하자. 인젝션.
인젝션. 딴 것이 있어요. 인젝션.
Okay.
딴 것이 인젝션 것이 있어요.
Let's.
Let's try.
Are you ready?
Yeah.
Inject.
인젝션.
Yeah. Okay.
Yes, this is a complex situation because Eberhard, it's what we discussed many times in regard to the two technique of pulling on the valve. Here it's so angulated that the pulling technique is not going to be so easy. So really here you have to maneuver your wire to be able to follow almost the pigtail. So your core valve catheter will probably follow, you know, a good angulation for the implantation. And like we did the previous cases, I would say that here it's also very interesting to try this technique, and it will work, I'm almost sure, and it will be much more comfortable for implanting the valve. So if you could, Eberhard, leave the wire a little to have the wire going close to the pigtail finally.
Yeah.
Because here you have to. Okay, Dr. Kim. Okay, much better now, the wire. So leave the wire to give attention on the catheter, and then you will face probably a good angulation to implant the valve.
Yeah. Let's
But again,
reposition.
it's not a simple case. Huh?
Let's reposition the. Shall we exchange to the other picture?
More some rigid.
You know, I would like to change, Jean-Claude. We are now, the patient is stable. Actually, the pressure is 84.
리지드한 거 있어요? 이
I would like to have it at around 100, but the patient is stable. And instead of messing around with the soft graded pigtail, I would exchange it to the. I'm holding the sheath. Okay. I think the pigtail is an important aspect here, and I'm usually very patient positioning the pigtail because it is your landmark, and particularly in a situation like this, I think we need good landmarks in order to position the valve correctly.
Pigtail with graded mark usually cause friction between pigtail, catheter, and device.
Yeah.
So personally, I use pigtail without grading.
Yeah.
The mark causes a kind of friction.
Yeah, can we go to,
Yes.
to right? I do the same thing. The reason why we did this, we had the pigtail in place, but then we were looking at this big anatomy, and we wanted to make sure that we're not making mistakes, and that's why we repeated the angiogram with the graded pigtail, and that was the reason. Well, that doesn't help a lot.
I think this case is a really tough and complex cases. One of the factors is the aortic valve is even though it's a tricuspid valve, however, it's functionally
Don't you have-
bicuspid
is this a
valve.
regular
And the second one is a very severe septal hypertrophy. So
Yeah.
we have to have caution during the stent deployment of the jump up the stent. And finally, the axis of the aortic valve is some unfavorable transverse location.
Okay.
So we'll combine the three factors.
Yes.
I think it's a really tough cases.
Well, thank you very much. The pigtail is in place now.
에어 빼세요.
We go back to LAO.
Yes. LAO 얼마였죠?
19요.
Can we do the 4x4s?
Well, JC, can you comment on the apparently mismatch of the annulus and the STJ and the ascending aorta? Because from the angio, it looks like a very huge anatomy, a very huge ascending, including the sinus area. But then using a 23, you can occlude your annulus.
Yes.
Can you comment on that?
Comment here, you know, maybe we should look back to the CT scan to understand if it's not completely sure that it's a tricuspid. Okay?
Fully done.
Because if you seal so nicely with a 23 milliliter balloon, you should have concern about it.
What about T at this moment?
Okay, we know
And
we
if
need
you
to
look
go
here,
more
for example, the
Quarter.
distance between the valve and the calcification on the
Metering,
LVOT,
yes.
it don't looks to be 27. It's way smaller than that. So, you know, and the catheter finally don't go, you know, deeper than the pigtail. So I'm still not completely sure we are not dealing with a bicuspid here. You know?
I'm not sure
So
either.
what I will
Jean-Claude.
do in the place of Eberhard, I will push
Just,
2 or 3 centimeters on the wire. You know, I will just push, but it's not Eberhard, it's Kim to do that. You know, to stabilize the valve a little better. You
2
should
to
advance
3
the wire
centimeters
for at
in.
least
Yes.
easily. Push on the wire 3, 4, 5 centimeters. It's
And-
not millimeters. You can
Test
advance the
it,
wire
test it.
much
Test
more
it.
to stabilize the valve.
Okay.
I think this is not
See
bad.
your ventricle, you see the ventricle. So you have a lot of room for your wire. It's a dilated ventricle. So you should advance your wire.
Can you do a little bit
If you
more?
want advice, I will advance the wire easily 3 or 4 centimeters. Then you stabilize more. For the implantation is important, you know. And I think you are a very nice position. It's,
Can we go a little
almost
bit more?
perfect.
RA,
A little bit more LAO.
LA.
Yeah.
Yes, that's a good point. Much more LAO again, to see better, even more. You know, to align the. What they try to do is to align the distal tip of the catheter, which is almost aligned. So it's allowed to see very
Enjoy,
nicely
enjoy,
also the
enjoy,
valve
enjoy.
itself. 0, 4, 6, 8.
Here you go.
This is perfect.
Okay, go on.
Yeah. Yeah, we start, I'm, as opposed to you, Jean-Claude, I'm holding it with 2 hands because I want to make sure I'm not slipping.
Yes, normally.
And maybe I'm not
you
too
can-
relaxed here. Okay.
No, but it's, I understand, but you have to go slowly. Now that the valve is implanting,
Go ahead.
Testing.
you should stop here and you should push on the wire 1 more centimeters.
Okay.
Push on the wire. Slowly, but push. Yes,
Yes, to
exactly,
make it more-
stabilize more and more horizontal.
Okay, go on.
Yeah.
So Eberhard will have nothing to do. If he's doing properly, he will walk nicely. So then you go slowly, and Eberhard will just have to pull very, very slowly at that time.
Stop.
While to pull to keep the valve a good position,
Test.
Test.
I think it's perfect.
Go ahead.
It's just perfect. Just continue slowly. So even if the valve move, by the fact to go slowly will allow you to modify, you know. Be
Slow
careful,
down,
you have
go down.
some diastolic and extrasystole, so this is not very comfortable. You know, I
Okay,
would
so
use
why don't we
pacing
just
here
go for
to
pacing,
stabilize.
65?
5.
Okay.
Especially you have huge
Okay, go on.
Keep going.
regurgitation, so you will have to implant
Okay,
during
65.
pacing, I would
Okay,
say.
okay.
Correct, keep going.
Not yet, but in a while. So if I was
Or
Eberhard, I
70.
will pull a little
70.
and Kim, I will advance the wire. Just advance the wire 1 centimeters. Push on the wire 1 centimeters.
Yes.
Can you advance the wire?
Yeah, yeah.
See. Advance slowly.
Yes.
1 or 2.
Yes.
That's fine. You stabilize it. Okay. And Eberhard, you should probably bring the valve a little higher. Just
Yeah, it's,
2 millimeters.
Yeah.
I think it's good. I think it's good. Leave it to expand it alone. You see, you just wait. This is the key. And if it's moved, you can react. So we just wait for you. And I think it's still perfect. It's going
ahead.
to
Go
the
ahead.
good direction. You know what I mean?
Yeah.
Yes.
So you should expand a little more, very slowly, stop again,
Test
and
it.
wait a while.
Angel.
And you can make an angio.
Angel.
Hold
It's
on.
not bad.
Angel.
It's not bad at all. You are going to be close below the calcification. Eh? It's a huge anatomy. It's not simple. Eh? So go very slowly. Just implant a little more and wait a while. Don't pull, don't do anything. And we will see if the valve is diving. Let's stay here. Okay, you should pace here.
Yes.
Pacing.
you should
Yes.
pace.
70.
At 160.
160.
160.
160. And you should push on the wire a little because the valve is diving a little. Better than to pull is to push on the wire a little.
The wire a little bit.
Yes.
Okay?
Yes.
And then you can deploy the valve.
Okay.
But push on the wire before a little. Yes, and now you deploy.
Grube,
Go ahead.
deploy.
Yeah,
Just go slowly and deploy. That's it.
go ahead.
And you pull a little, Eberhard, because otherwise
yeah.
it's a large anatomy.
Go ahead. Go ahead.
Yes,
Okay, deploy the valve.
very gently.
No, you can't go
Pressure
faster now.
Yes, yes. They have to deploy. Just deploy, and then you can stop the pacing in a while.
Okay, hold on.
Decrease and stop the pacing.
Pacing stop.
It's
Stop.
a bicuspid, I guess.
Yeah, it's bicuspid. So push the
It's
wire.
a
a little.
bicuspid because you are
Yes.
distant. You know, you cannot.
I think it looks not so bad.
Yes. Tester.
It looks good, no?
Yeah. I
Yes,
think we
it
can
looks good, but you
deploy.
cannot
Actually,
reach-
can we see the?
Oh
the-
yes.
Can we see the arch?
What you can do is to
Good.
to take off the wire, because you don't need the pressure on the catheter anymore.
Yeah. You mean you pull back the wire?
Yes, pull back
Yeah,
the
yeah.
wire. It's no need. The pressure on the wire is not any more
Okay.
mandatory.
Can go.
Your
Keep
frame
going.
is expanding.
Yeah, a little-
You are
pull
in
a
a
little
good
back.
position.
Pull a little back.
Pull.
Yeah, pull back a little bit to have enough. Okay, for the time being. So now you can deploy.
Continue.
Continue.
Here. Yeah.
Take off the wire even more. You don't need all this wire.
Okay.
Especially if it's stuck. Okay, it's not stuck. That's good.
So
Okay,
deploy.
it's perfect.
Deploy.
Yep.
So you leave the pigtail, Eberhard. You like that, huh? Well,
like
the
it.
aorta is
No,
so
no,
huge
no,
that
you
there
have
is
to
no
do the other
danger.
way.
Yeah. Yes.
No.
I'm sorry.
You are recapturing the valve is
Yeah.
not working.
Now,
It's not the good catheter.
Okay. Why don't you remove the
Probably in a
tail?
few months you can do that, but not yet today.
Okay. Oh,
At
sorry.
least it's not working.
Okay. Okay.
wire is out. Can we take
Oh,
the
well
wire
done.
out?
Tail out.
107 to 51. Yeah, take the wire out. I mean the wire. Okay.
No?
Yeah, no. I mean the pigtail. But the wire is out now, so we can might as well.
So take everything out now.
Yeah.
Because it's,
Oh,
why is
sorry.
no more there?
We capture it.
There's a heavy calcification. There's a heavy calcification, so there's high possibility of paravalve leakage. So
Yes.
I think we have to put the wire on side
Yes, but you
So
know
why is it-
something
because
that we.
it requires additional
No, 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 no.
dilatation.
But just remember
Put
that
the-
the 23
the-
millimeters balloon was sealing.
Don't worry about the pigtail.
So if you look the diameter
Yeah,
of the femur,
no,
it's probably
wait.
22 or 23.
Okay. See?
So you could
So
see
keep the wire in
despite
and this
it's
one
very
out.
surprising in regard to the anatomy because I still believe
Go ahead.
it's maybe
Take
a
the device
bicuspid.
out. Keep the wire in.
So
pigtail.
let's see. Okay, if it's huge reputation, I'm wrong. But if it's not, it's validating. finally.
look,
And
look,
we
look.
We will ask them to go in the opposite direction.
What happened?
This is Guan from Samsung Medical Center. It's quite interesting that the leave the pigtail during the stent implantation. Is it risky, especially patient with a severe calcification?
No, it's not
Is it
risky.
safe to-
I've done 500 cases now and never got the pigtail caught. So I like it there. And let's go step by step. We still have some questions to answer. First of all, I'm very happy with what we see. The pressure is 125 over 60. That tells you that hemodynamically at this point, without any support, we are okay. At least there's nothing dramatic to expect. Second, we know, looking at the pigtail and at the core valve, that probably we are okay in terms of deployment. And thirdly, I would think that when we put the wire back into the ventricle now in order to measure the hemodynamics, but I would not expect a lot of problems. And in order to show you that the pigtail that's there is not a problem, I will show you how we take it out. And I can assure you that when it's the feed and pull thing. It gives, at least in my personal experience, it gives, in a questionable anatomy, it gives the valve a little bit more support even. And the thing that I like, you see, the pigtail moved, which tells you it's not trapped. You know what I mean? So here we go. And you know, cardiologists, interventional cardiologists are trained by markers, balloon markers, wire markers, and I like during the last deployment phase, and potentially the valve can jump, I like my reference point in place. That's why I always keep the pigtail there to make sure we are in good shape. Actually, I think given the look at the valve, it looks okay. The hemodynamics look good. Echo, can we talk about the echo?
Dr. Kim?
Yeah,
What of the echo?
the ventricular end-side properly placed in long axis view, right here, and in color flow imaging, you can see the palpebral leakage right here.
So shall we?
In short axis image,
Shall we exchange?
pigtail.
Yeah.
the circumferential extent of palpebral leakage is more than 10. It seems to be moderate, at least moderate palpebral leakage.
Regular wire. Teflon.
So what's your AI assessment?
Moderate.
Moderate.
Yeah.
So we'll keep this, and we just put the second wire in. I mean, the second balloon, unless SJ is waiting for his case, but please let me know.
Post-dilation.
Okay, so I have the
pigtail.
but looking at the picture,
Can we see the frame? Can we see the frame of the valve in another projection?
of course we can.
아래요.
Actually, I would like to show you. Let me just put the pigtail in, and then I would like to show you the view that we usually take in Bonn, in Germany,
긴 거 없나?
looking into the valve and see whether it's round.
아, 긴 거 없었어?
더 나와, 더 나와, 더 나와, 더 나와.
Do we have an exchange? Okay.
안 나왔어.
Dr. Grube,
Yes.
Dr. Grube,
Yes.
can I ask you a question?
You can always ask.
This is Chen from Hong Kong. But this is a very calcified valve. So do you think that the amount of cerebral embolism is correlated to the amount of calcium in the valve?
하다한 거.
We got excellent lectures by Dr. Yi on all these cerebral protection devices. So if these devices is available, do you think that this is a good candidate for us to use the cerebral protection devices during the TAVI procedures?
Yeah, well, we know that. At least I would think that. Let me just see here. Hold on a second. Can we just move the projection to the extreme RAO all the way?
아래요.
Stop. Now cranial.
그러냐?
Hold on here. The anesthesiology. See, you have an
While you are
idea.
trying to re-enter the
So you can see here the valve looks at least fairly round.
Circumferential.
Yeah? It's not too bad, actually. Jean-Claude, what do you think?
I agree with your comment that is not very oval, but it's still oval.
Yep.
It is not clarifying the debate between bicuspid and tricuspid, because I still cannot understand completely the diameter that we got by CT scan, the result with a 23 millimeter balloon with no leak, and a frame that is constrict to 23-24.
Okay.
So that let me think
Different
that if you do a CT scan here, I will bet that you
You know what?
finally
Why
implant
don't
in
we
the
do an
bicuspid
angiogram?
valve.
Yes.
Shall we do an angiogram?
엔조.
Well,
엔조.
that would be
Angel.
great.
자, 엔조. 준비.
어디?
스네. 엔조.
슛.
Yeah.
You have a
Moderate.
registration.
That's the moderate part that he sees. So we would like to do a post-dilatation to bring the valve up there on top. Is that okay? The hemodynamics are actually not bad.
Yes.
Yes.
So this is good, and we will be Would somebody give us an update on SJ's case? So we're not holding him up.
Another option is to wait for another 10 minutes to let the valve frame expand further, leading to reduction of aortic regurgitation. Okay.
다시 보자. 아까 와이어.
Easily.
아까 하드 와이어.
아까 하드 와이어.
This wire is okay.
So we changed the wire.
Okay, so can we do the
Previous one.
hemodynamics?
끝나고 바로 가면 돼.
아, 아니 프레셔 와이어.
Eberhard,
Yes.
we are going to move on the SJ box case.
Okay.
So, Dr. Won-Jang Kim,
Yes, I am
would
here.
you please explain?
Yeah, this is the final angiography. So previous the post dilation using the 25 the GMED balloon. Okay.
How do you think of the depth of the valve at the left coronary cusp? A little bit deep.
You mentioned about the left.
Subscartal leakage.
You mentioned about the
left
left coronary
RCC.
to the some depth. Yes, little deep, deep first the previous one. Some almost 8
Is
or.
this subscartal?
What? If you look carefully of the sinuses, if you go on the left sinuses, it's not so deep because this calcification is not the annulus.
Just around
it's
the
leaflet
6
finally, and I think it's probably the raphe because your frames stay quite a distance from the annulus.
Yes.
If you look carefully. And I think it's, yes, for a bicuspid, it's a little low, not too low, but a little low. I think it's something that you cannot achieve very easily to implant the valve higher. You know, it's, as you have seen, it's complex situation here. Huh? So again and again, despite the 25, you are not reaching 25. If you could show us the balloon inflation, will be very nice to see if the frame is expanding or not.
Full expansion.
Can you share with us the balloon? Yes, the balloon inflation.
Yes.
Yeah, 25.
Just for our knowledge, to see how what's happened. You know, to see if it's large or not. You see, it's not so effective. You know, it's not a very effective balloon size finally because you are reaching the frame, but still we see some kind of a gap between the frame and the balloon. So it's I would say not a very effective balloon valvuloplasty.
Yes. So after that,
But also we see the anatomy that is there is a very thick, leaflet or raphe or whatever at below the left ostia. So this is most likely, a bicuspid valve. I'm almost sure. And the assessment of the PVL, it's a grade 2+. If you have time, it will be very, very nice to do the same angio with the same contrast on the right projection. Because it could be, assessment of PVL have to be follow, some very strict rules, and we could have another point of view of this assessment of PVL with this angio. So if you have 2 or 3 minutes to dedicate for us, if you agree, if the patient have not a severe creatinine or level, of course, but if you can do again a 20-25 cc contrast injection in a right projection with caudal to align the frame, it will be very interesting to see the final angio, the final PVL. Can you do that for us?
we cannot. So we already finished the cases. Anyway, the diastolic pressure is around the 70. So that's why
so all of that.
The hemodynamic is
How was the finding of TE that can help differentiate between suprascutal versus paravalvular leakage?
Unfortunately, some echocardiographers said to me the degree of the paravalvular leakage is not too much improved. Some exactly the similar from the previous balloon. So.
It's not a good projection for that.
Jean-Claude, can I comment on this case? Yeah, I think the size of the valve is undersized, and I think 31 is appropriate to prevent the PLV. And in that situation, it is difficult to control by transfemoral approach. So I'm a cardiac surgeon, so I prefer to do the direct aorta approach by mini thoracotomy. So it's much easier to do, especially in this case.
So I agree with the comment that valve may be a little bit smaller, because in perimeter, the perimeter of 86 millimeter recommends a 31 millimeter valve, but after angiography, Eberhard decided to choose a 29 millimeter valve. How was the EKG change?
The EKG is new developed left bundle branch valve.
Newly developed
Yes.
LBBB?
Yes.
Okay.
I think don't forget that the valvuloplasty, the 23 balloon showed very minimal AR. So I think 31 on retrospect, maybe 31 better, but you know at the valvuloplasty time it looked like there was no AR, and I think 29 is okay. I think there's just too much calcium, and some of these valves, no matter what size you use or how much valvuloplasty you do post implantation, you cannot reduce the AR because a big chunk of calcium is just inhibiting the full apposition of the valve stent to the annulus.
Is there any comment from panels? Yes, please.
Thanks. I'm Dr. Esther from Japan, and the SB a fellow in Massy, France. And nice case, but we had the case series of the 21 cases by bicuspid valve, and after implantation of the core valve, the strut could be more elliptical compared to this case, and because of the low radial force. And I assume that this is my guess, but the position, the depth of the core valve could be one of the reasons for this kind of the aortic irrigation. You don't think so? Or if so, that we could put the second valve, or what do you think of this idea?
Well, here, what could be the strategy if you are not satisfied?
Yes.
Yes. I think you cannot pull the valve in an upper position if you define that it's too low. So if the mechanism is a too low implant, the second strategy is the valve in valve. Using the same, because if you look carefully on this projection, the skirt frame is aligned. So it is a 24, finally, annulus, whatever. Here is not going to 29, or even if you have used a 31, probably the final aspect of the 31 will be exactly like this, if I'm not wrong. You know what I mean? And that's why the balloon was sealing, the balloon of 23 was sealing, because the functional anatomy in here is not a 29 or 26 or 27, it's most likely a 24, maybe 24.5, I don't know, I'm not sure. But it's certainly not a very large orifice, functioning orifice. That's why this finally frame is not, expanding, and it's a little externalized in the LVOT. You are distant from the left, you see the left sinuses. There is quite a huge gap here, major gap.
Yeah.
You know, how to explain this gap? It could be the calcification, I agree. It could be a tricuspid with a huge calcification. But I'm not sure you can win. You can take the risk of taking a 28 balloon. It will not destroy the valve, but the answer will not be what you expect. The frame will not expand if it's a bicuspid, except if you rupture the raphe.
So John, if after the balloon dilatation still have a severe degree of paravalvular aortic regurgitation, so how will you tackle this complication? Would it be logical to put in a valve in valve with a 31, or what is the advice for that?
Before deciding the correction strategy, we have to differentiate the reason of paravalvular leakage. Is it really paravalvular leakage due to asymmetric calcium nodule, or is it suprascutal? If it is paravalvular leakage due to calcific nodule, then we try once again a bigger balloon. But if it is suprascutal, we have to put second valve. So to differentiate between two causes, it is very important to see the TE.
And yes, again and again, it is crucial to assess properly the PVL. Because to take a decision that have consequences, potential consequences, you have to be convinced of the level of PVL you left to the patient. So here we are debating about the angio. We don't have the echo, we don't have the MO. Again and again, this is 15 to 20% of the TAVI procedure that you have to debate what to do. So we need for these 15, 20 cases, more than just an imaging or more than just hemodynamic. We need at least two. If possible, when you deal with complex situation, they have to be done in general anesthesia with TEE. Then you have, most likely you will define the good strategy rather than trying to assess here, oh, but it looks like it's a grade 2 plus PVL, so it's huge. Yeah, but we do know that it's not perfect using just angio. If you don't do it properly, if you don't go in the other projection, if you go in the right projection, maybe it will go down to 1 plus. You will be very surprised. And if the valve is properly positioned, even a PVL grade 2 have a tendency to decrease with a self-expandable device. So it is not to rush. Again and again, it's what I highlighted. PVL, maybe here we make a mistake. Maybe we should have use a 28. But it's not the end of the story. You can follow your patient. You stop the strategy at that stage because your feeling is, okay, I'm not sure it's 2 plus, because the echo was saying, we had the echo before, it was mentioning it was moderate, if I don't say mistake, The hemodynamic, we didn't have any data, but they cross it and they probably measure it. So it will be very nice to share with us the hemodynamic, to see if you have an end-diastolic of 10, you can go home. The patient is going most likely to go fine, because you have the echo and the hemo that will be in favor of a good result, and the angio, a concern, a concern, but not in the right projection. So I will be kind to just stop the procedure there and wait to see the follow-up. It's not a big issue. You can do the balloon with 28 in 2 weeks, in 1 month. It's not a big issue. You don't leave the PVL forever, So you can just say, okay, this patient, I left the PVL that my assessment is not perfect. Let's see what will be the outcome. If he's going very well, you follow at 1 month, 6 months, he's going fine. And you will be surprised to see the PVL have decreased in between. If it's the opposite, then you know that you can change the strategy. Balloon with large size, diameter, valve in valve, whatever. You should not lose a patient because of a PVL. This is what I want to insist. And the mortality in relation to PVL made me think that is probably a part is the patient are not followed properly, because they should not die. This is not going to give a sudden death. It's going to give some heart failure. So it's coming from that, and you adapt your strategy.
Last quick question, Dr. Ye.
Just a comment. I think this valve is due to the calcifications, maybe not to the size. And you just see the shape and the pattern of the leak. It's very eccentric, like symmetric. And I think it's due to the non-symmetric calcification, and with this self-expanding valve, that's probably is a little bit, I understand, as a disadvantage. So I have a questions to the panel. Do you think this is initially, if you see this kind of asymmetric bicuspid calcification, do you think the sapien valve will be more suitable for this patient rather than the self-expandable?
Yes,
I think it's, the final angiogram is the best option in the current situation. Functionally, it's a bicuspid valve. And the severe calcification, even though there is some moderate paravalvular regurgitation after the stent deployment and the post-dilation, I think that is the best clinical decision for this patient in this situation.